Hey all, as promised, since we missed the last portion of this PowerPoint presentation, I have completed an audio recording for you. So we did talk in class about care of clients living with respiratory disease, specifically asthma, and now we're just going to finish up with COPD. So I'm just going to scroll all the way down here to COPD, and then we'll chat about that. So chronic obstructive pulmonary disease. So COPD, like I had mentioned in class, encompasses two things. One is emphysema and one is chronic bronchitis. A patient can either have emphysema or chronic bronchitis or have a combination of the two. It is caused mainly by cigarette smoking, and it is characterized by progressive, partially reversible airflow obstruction. It has systemic manifestations, meaning it affects our whole body and every system. And usually over time, individuals with COPD have an increasing in the frequency and severity of the exacerbations. And if you look over here at the picture, it kind of differentiates emphysema and bronchitis. So chronic bronchitis is really just chronic inflammation and thickening of the walls of the bronchial tubes, which over time narrows them. This starts to induce coughing spells and making dyspnea an issue. With emphysema, the alveolar walls are damaged. They can lose their natural elasticity, become overstretched, and rupture. Several of the alveoli around it may also rupture, forming one large airspace instead of many small ones. So we'll kind of break up chronic bronchitis and emphysema and talk a bit about each of those. So chronic bronchitis is excessive production of mucus in the bronchi, accompanied by a recurrent cough that has to persist for at least 2 to 3 months over 2 successive years. There's a disappearance of cilia, there's chronic inflammatory changes and narrowing of the airways, both small and large. There's increased risk for bronchial infections, and because patients with chronic bronchitis often are at risk for infection, these repeat infections cause scarring of the bronchial walls. With emphysema, there is destruction of the alveolar walls and abnormal permanent enlargement of the alveolar air spaces, And basically what this does is it leads to hyperinflation of the alveoli, destruction of alveolar and capillary walls, narrowed small airways, and an overall loss of lung elasticity. Because of the loss of alveolar walls and capillaries, surface area for O2 diffusion decreases, and this is what causes an increased respiratory rate, shortness of breath on exertion, and rest for the client with emphysema. If you minus this little video here in PowerPoint presentation, there is a YouTube video that I was going to show you in class about a lady with her experience with emphysema. It's a great video. I really enjoy it. Please take a few minutes to watch the video. The next 2 slides talk about the physical exam. The physical exam is really important in order to differentiate between both chronic bronchitis and emphysema. These 2 slides will be useful in assisting you in studying for your upcoming test next week. It really helps you differentiate between the 2 diseases and their processes. By primary pathology, the appearance of the patient, symptoms the patient is experiencing, the lung assessment and what you may hear, arterial blood gas results, and oxygen saturations. We briefly reviewed this slide in class and talked about diagnosing these patients based on their appearance. We know that this gentleman here looks like he has emphysema. He has the barrel chest, he's thin and frail looking. Whereas these 2 gentlemen over here on the right look like they have chronic bronchitis. They're a bit overweight, they're coughing, they have some cyanosis going on. Again, if you decrease the size of this video here in PowerPoint presentation, you can watch a little video on reviewing COPD. Since we know that smoking is the #1 thing that causes COPD, I just wanted to talk about the effects of tobacco smoke on our respiratory system. It's basically the cause of 80 to 90% of COPD patients. The other causes can be environmental and work hazards. So effects of smoking: decreased smell and taste, hoarseness of the voice, bronchospasm and cough, an accumulation of sputum, which then causes more of a cough. It causes hyperplasia of cells, which leads to an increased production of mucus. The hyperplasia reduces airway diameter, which makes it more difficult to clear secretions. Other causes of COPD include infection, so recurrent respiratory tract infections can aggravate and make the progression of COPD worsen. Air pollution, such as occupational chemicals and dust. Hereditary, although it's more greatly affected by smoking and exposure to secondhand smoke. And aging. As we age, we have a loss of elastic recoil, lung size, and number of good alveoli. So just some quick stats on COPD. The estimated number of people with COPD has doubled in the past 25 years. The number of women with COPD is increasing because more women have smoked for more years. 4% of all deaths in Canada, which this is probably underestimated, is caused by COPD, and more than half, or 50%, of COPD patients will die within the first 10 years of being diagnosed. COPD clinical manifestations overall include dyspnea or shortness of breath, difficulty breathing, activity limitations, cough, weight loss, and anorexia. The nursing assessment for the patient with COPD is important. It helps us to determine the severity of the disease and impact on the patient's quality of life. We need to identify tobacco consumption, assess the level of their shortness of breath and if it affects their ADLs, if they use home oxygen or not, and how much they use. We need to assess their vital signs and oxygen saturations frequently if they are admitted to hospital with a COPD exacerbation. Some of the physical exam might include ankle swelling, weight gain or loss. Weight gain is more common with chronic bronchitis, where weight loss is more common with emphysema. Muscle wasting, anxiety and depression, the presence of fine or coarse crackles, extra heart sounds, and a barrel chest. The nursing care really focuses on smoking cessation and education, drug therapy, oxygen, nutritional education, and pulmonary rehab. Smoking is the most significant risk factor in slowing the progression of the disease. For drug therapy, medications for COPD can reduce the intensity of the symptoms or abolish them altogether. It increases their capacity for exercises, improves their health, and reduces exacerbations. Oxygen is frequently used to achieve saturations between 88 and 92%. The goal is to supply adequate oxygenation to minimize the oxygen carrying ability of the blood. Oxygen delivery can be high flow or low flow. You should review page 741 and 742 of your textbook. Nutritional therapy, weight loss and malnutrition can be common, especially in the emphysemic patient. Energy expenditure is increased because their work of breathing is increased. Pulmonary rehab and activity. There are many programs available for pulmonary rehabilitation. So this is just a slide on health teaching, what we should teach our patients who suffer from COPD. Health tips on what you can do. So COPD is a breathing problem. It becomes worse over a period of time, and this is what you can do from a patient perspective to help your COPD. Oxygen therapy is considered a drug that raises the partial pressure of inspired air. The long-term use is intended to keep oxygen saturations greater than 90%, although 88 to 92 is pretty normal for a COPD patient. When they're getting less than 90, especially when they're on oxygen, we need to think, why are they starting to come down with a respiratory infection? Hypoxemia is present with acute exacerbations or infections. The methods of oxygen delivery for a patient with COPD can vary. Nasal prongs or nasal cannula is the most common method of oxygen administration. However, some patients may require a face mask, non-rebreather, or venturi mask, especially when an acute episode or exacerbation is happening. Weight loss is common, especially with emphysema, and eating becomes quite an effort because you are so short of breath. Resting before meals, taking your bronchodilators before meals, eating smaller and more frequent meals is all a part of the education that we should be doing with our patients. Increase their calories, give them more protein, use nasal prongs while eating, and providing them with adequate fluids. What if your patient needed a venturi mask for an acute COPD exacerbation? What will you do during mealtime? The answer is change it. Maybe go to high-flow nasal prongs or humidified oxygen. That's something you can do working with the respiratory therapist. There are several medications used to treat COPD. Beta agonists are medications that mainly affect the muscles around the airways, such as the bronchi and bronchioles. They are called agonists because they activate the beta-2 receptors on the muscles surrounding the airways. Activation of the beta-2 receptors relaxes the muscles surrounding the airways and opens them up. When the lungs are irritated, bands of muscle around the airways start to tighten, making the airways narrower. This often is what results in breathlessness or shortness of breath. Beta agonists work by telling the muscles of the airways to relax, widening them. This results in easier breathing. Anticholinergic drugs pertain to a blockade of acetylcholine receptors. This results in the inhibition of the transmission of parasympathetic nerve impulses. Anticholinergic medications are another group of bronchodilators that are different from the beta agonists. While the beta agonists affect the bronchioles or small airways, anticholinergic affect the muscles around the bronchi, the large airways. When the lungs are irritated, these bands of muscle can tighten, making the bronchi narrower. Anticholinergic medications work by stopping those muscles from tightening up. Complications from COPD can be scary for patients. Acute exacerbations of COPD are usually caused by respiratory infections, and more specifically, pneumonia. Sleep disturbances, the inability to lay flat. People with COPD sometimes have to sleep sitting upright in their chair. Depression, anxiety, and panic related to breathlessness, a loss of independence, and an inability to complete ADLs is another complication. Cor pulmonale, hypertrophy of the right side of the heart with or without failure resulting from pulmonary hypertension. Pulmonary hypertension results when pulmonary vessels constrict in a response to alveolar hypoxia. The right side of the heart must push harder to get blood into the lungs. Eventually, right-sided heart failure develops. Long-term oxygen therapy can reverse the progression of pulmonary hypertension. CO2 narcosis. So usually the brain's respiratory center responds to excess carbon dioxide in the blood to stimulate breathing, meaning when we have too much carbon dioxide, our body knows that we need to breathe faster to get it off. Low oxygen levels now provide the stimulus to breathe. It's still important to give patients with COPD oxygen, but we really need to be careful about the titration process. In COPD, there is a chronically high CO2 level called hypercapnia, which knocks out this response. CO2 retention is due to increased airway resistance, which creates respiratory acidosis. Environmental lung disease. Some of the signs and symptoms of environmental lung disease may not appear for 10 to 15 years, but could include dyspnea, cough, pneumonia, chronic bronchitis, emphysema, and lung cancer. Diagnosis and treatment includes pulmonary function tests, chest x-rays, and a CAT scan of the chest, and the overall goal is to improve ventilation and reduce exposure to smoke. This is just a picture of what asbestos looks like on an x-ray. We have already reviewed these questions, but I'm just going to go through quickly and give you the answers again. The question is, what are the common effects of cigarette smoking on the respiratory system? And the answer is D. Which of the following elements should be included in a plan of care with the client with COPD? The answer is B, as in Bob. Which of the following is one of the most important things that a nurse can teach a client with COPD? The answer is D. And what is the major advantage of a venturi mask? The